Let's tackle a high-yield FRCEM final SBA question on managing anaphylaxis in children. This is essential knowledge and should be easy marks in the exam. Here's the scenario. An 8-year-old girl with asthma presents with sudden facial swelling, difficulty swallowing, and abdominal pain after a wasp sting 15 minutes ago. She's had similar reactions before. On exam, she has periorbital edema, stridor, and a diffuse wheeze. Her vital signs are concerning: respiratory rate 35, heart rate 140, blood pressure 85/50, and oxygen saturation 94% on room air. Paramedics gave her 1 intramuscular adrenaline dose 10 minutes ago, but she's barely improved and looks more distressed. The question: what's the most appropriate next step in management? Here are your options. A. Administer intravenous chlorphenamine. B. Give a second dose of intramuscular adrenaline. C. Start an adrenaline infusion. D. Perform urgent intubation. E. Commence nebulized adrenaline. Take a moment to consider. The correct answer is B. Give a second dose of intramuscular adrenaline. Why? This child is in ongoing severe anaphylaxis despite the first adrenaline dose. UK guidelines from NICE and RCPCH clearly recommend repeating intramuscular adrenaline after 5 to 15 minutes if there's no improvement or if symptoms worsen. It's been 10 minutes here, so a second dose is both timely and appropriate. Let's quickly review the other options. A. Intravenous chlorphenamine is not first line and won't reverse airway or cardiovascular compromise. Antihistamines are adjuncts, not emergency treatments. C. Starting an adrenaline infusion is reserved for refractory cases after repeated IM doses and requires close monitoring in a high dependency setting, not the immediate next step here. D. Urgent intubation, while tempting given the stridor, should be avoided until you've given a second adrenaline dose. Early intubation carries risks and may be unnecessary if symptoms improve. E. Nebulized adrenaline is not recommended for systemic anaphylaxis and doesn't replace intramuscular administration. Key takeaway: in pediatric anaphylaxis, intramuscular adrenaline is your first-line lifesaver. If there's no improvement within 5 to 15 minutes, give a second dose promptly. Always monitor closely for biphasic reactions and support circulation with fluids if hypertension is present. Antihistamines and steroids come later and should never delay adrenaline. For more practice like this, with over 40,000 questions and 20 mock exams covering every emergency medicine topic, visit eemfinalexams.com. Sharpen your skills and pass your FRCEM final